Hello, everyone. Welcome to our very first episode of Alive and Kicking, where we sit down with a different health professional each week and uncover the truth about a health norm that we all just accept. So this week, we're busting some myths with Dr. Christine Catling, a senior lecturer and director of midwifery studies at UTS. She's also part of the Maternal, Newborn and Women's Clinical Academic Group at Sphere. A lot of Dr. Catling's work looks at the norms that come with giving birth in Australia. She really has some amazing insights into what needs to change in order to improve the experiences of people giving birth in Australia. So let's hear what she has to say.
Alive and Kicking, a podcast by Sphere.
Okay, so the first thing that we wanted to talk about was your CAG and what you guys actually focus on. If you can just tell us a little bit about it all, that would be great.
All right, so my CAG, which is a clinical academic group, is the Maternal, Newborn and Women's Clinical Academic Group. So we're part of the Sydney Partnership for Health Education, Research and Enterprise, which is much easier to say in its acronym, which is SPHERE. And we also have an Aboriginal name that's gifted to us, which is Maradulu Vidyari Gumal, which means working together for good health and well-being. So we obviously focus on maternal, women's and newborns' health and research. So the history of SPHERE, just a real short potted history. So in 2016, there was a competitive process and 12 CAGs were accredited. So they've been funded every year following an annual performance review that's assessed by the SPHERE Council. So a few years after the inception in 2016, 4 more CAGs joined SPHERE, so there are 16 altogether now. So they all have a health focus and they range from our CAG, being maternal, newborn, women's, to cancer, ageing, paediatrics, urban environments, early life determinants of health. There's an Aboriginal CAG, cardiovascular genetics, there's lots. So I co-lead this CAG with Associate Professor Amanda Henry. She's an obstetrician and researcher based at St George Hospital and Uni of New South Wales. And our main aim is to mobilise, drive and accelerate research translation towards improving healthcare outcomes and also towards better value care, really. So the membership of our CAG comprises clinicians and so they are midwifery, they come from obstetrics and gynecology, medicine, dentistry, public health. We've got GPs, we've got neonatologists, implementation science, academics, and of course consumers as well, so the women. And these are all instrumental in ensuring the projects that we're involved in are relevant and necessary. So that's always a really important input. We do a lot of networking. So the CAGs don't work in isolation, so we often collaborate with other CAGs on research projects that we do. So we bring together the research and the education and other clinical partners to improve the health and well-being of women and newborns. Our clinical partners are in Southeast Sydney and Southwest Sydney local health districts. So there's quite a few maternity units in those districts that we work with and collaborate with various research projects.
Cool.
Yeah.
Okay, so can you give an example at all of any of your research projects that you've done in the past?
Sure. Our main flagship project has been about timing of birth, so we've been focusing on that in the last few years, and we used a mixed methods approach to study planned birth, which is comprises of induction of labour and pre-labour caesarean section. So we gathered data from 8 hospitals within southwestern Sydney and southeastern Sydney to map and make sense of the clinical variation. So women have inductions of labour and they have caesarean sections. This is part and parcel of some women's maternity care, but different places were doing different things in relation to the policies and protocols and the way they guided women through those procedures. So we looked at all of those 8 hospitals and just made sense of what was going on, really. So it did find that there was quite a lot of clinical variation, even though we have similar New South Wales health policies, protocols, and the research is all out there. Sometimes various places interpret it quite differently.
Right.
Some hospitals all do slightly different things. So that project was quite considerably huge anyway, but it led to the need for a better and more tailored communication strategy between women and families in relation to things like induction of labour and planning their birth. And so now we're focusing on a project called the Shared Decision Making Project. So this is led by my colleague, Associate Professor Amanda Henry, who co-leads the CAG with me. So this shared decision-making project, its main aim is to develop and pilot a training intervention for clinicians who work in maternity care. So that's obstetricians and midwives, providing that care at the 3 major hospitals in southwest Sydney and southeast Sydney. So that's where we're piloting the work, and so we plan to evaluate the acceptability, the feasibility and the effectiveness of the training using qualitative and quantitative measures. So we're putting together a lovely little package, and we're going to get the clinicians to come and do the training intervention and then really see how it works. And then hopefully further down the track we'll roll it out and we'll really get to grips with how it actually works for women as well, because they are obviously the end user, the recipients of these communication techniques and these shared decision making techniques and skills that clinicians, will have varying levels of anyway, but we're aiming to enhance that. Right. So the objective is to strengthen that capacity between clinicians and women, especially when there are many reasonable ways to manage the timing of birth. So sometimes there's not like one clear way to deal with a situation in pregnancy. There sometimes is, but sometimes it could be, we could do this, and we could do this, and we could do this. Right. And you have to take into account what the women prefer. Everyone is an individual. So this approach, this communication strategy, will help with the decisions about induction of labour, cesarean sections. So it won't be a top-down approach. A woman won't come to see a clinician, obstetrician or a midwife who will then say, we need to do this. It will be very much, the power level will be an even keel. So a very individualised, respectful way of communicating all of the ways that she could be cared for and catering to the woman's wishes as well. So the use of these advanced sort of communication skills really to share that decision making, and that's why it's called the Shared Decision Making Project. So taking into account that the final decision is always the woman's decision. Okay, so that is just a given anyway. So that's one of our focuses of work this year. We do have many research projects, and they're led by different people, very wide and varied. But that's one of the main projects that most of the CAG are involved in.
Right. Yeah, that's so interesting, because if you hear from a lot of women, it's quite common that, especially if it's their first time mothers, you hear a lot of people speaking about their own birth in a hospital as if the decision wasn't up to them, or they felt like they were totally out of control. And that's not even just something that comes with birth. Often people have that experience in all different areas of health where they feel as though it's not their decision, even though it's their body.
Absolutely. I mean, we're focusing on these particular issues, but this needs to be rolled out hospital-wide with whatever is going on, So it's skills of the clinicians, and we can enhance those and make that work better. So I think there's definitely a need for it.
Okay. Do you have any ideas about why young people would be interested, or why this is an important CAG for young people in particular?
Yeah, absolutely. So young people should be interested in the CAG. Well, most people are going to be parents at some stage. I mean, there's obviously the choice not to be, but a lot of people will become parents, in their early 20s, middle 20s, late, the average age of a woman having a baby now is 30. So any issues that relate to the care of women and young families and newborns should be interesting to them, really. So too many people go into parenthood without thinking about what the issues are and how to communicate with your individual preferences to healthcare professionals, or even working out what they are in the first place. Yeah. Knowing about the different ways you can be cared for when pregnant. I imagine young people would think there's just one way. There isn't. There's many different ways. So to find out about that, what the best care is, which, everybody wants the best care. And again, that can be cultural. In this country, often people thinking having obstetric-led care is the best care, and it could be if you have medical issues. But there is high-level evidence that shows that midwifery-led continuity of care is actually safest for women to have. any element of continuity of care is vital when you have pregnancy, birth, labour, postnatal period. That is always a really excellent thing to go for. I mean, I'm a midwife. I'm slightly biased, but anybody who knows who works in the maternity space knows that midwifery continuity of care is the gold standard and absolutely the best way to be cared for. So it can reduce levels of complications, in particular morbidity and mortality in babies. And that's all backed up by, like I said, high-level global research. So as a young person, if you are a healthcare professional or interested in becoming one, you can join our CAG and get involved in research. We also have a clinical internship program, which is particularly successful. It's been going on for the last 3 years. And what that involves is we pair interested clinicians within southwest and southeastern Sydney local health districts with academics to help complete a project. And it can be a year or 2 year partnership, and we can teach research skills. So they usually have a little project that they come to that they want to complete, and we help them do that. So it's been hugely successful, and it's been quite a stepping stone for some clinicians to enter into a research degree as well. Yeah. So it's not just UTS that's part of this CAG. We have UWS also, and Uni New South Wales. So those clinicians that do the internship program has been great. They have 6 workshops a year. They learn about all different research techniques. And also, if you're not a clinician, you are a consumer, so you're a woman, maybe you've had a baby or just interested in the whole space of maternal, newborn and women's care, you're quite welcome to contact us and get involved that way.
Okay, and what are the best ways for people to contact you, or even if they're just interested in your work or want to learn more about it?
Sure, we have a website, and the best way to find it actually is not by Googling Sphere, it's by Googling our Aboriginal name, which is that Maradulu Budyari Gamal. I'll have to give that to you.
Yeah.
And so if you go on there, you can click onto each of the CAGs and see what they get up to. So obviously ours is there, and then there's a link to the project officer, Tina. So her email is there. So anybody can contact Tina, and she will be very happy to let you know how you can join our CAG.
Okay, cool. Well, thank you for answering these questions. Actually, as you know, I'm a BCII student, but I'm really interested in midwifery. So I don't know, I think I will study that eventually. It's so interesting hearing your perspective as a midwife as well about the areas you think that this can grow and how we can provide better support for people like in the process of becoming parents and stuff. So thank you so much. I think a lot of people, this is an area, as you said, that they don't really think about until they're in the situation, and even then they don't understand the different options. So it really depends, you know. Even just being newly pregnant, you just usually go to your friends and family, and that's where the cultural aspect of things come in. So you often do what your friends and family advise you to do. But even if you go to the GP, who may or may not give you a whole scope of options, you may get led down a path that you don't necessarily want to go into. So it's worth looking into before you become pregnant, but not everybody is so organised. But so I think your first port of call could be a midwife, who can sort of usually point you in all sorts of directions of options, and it also depends where you live as well. You know, geography. You know, if you live in a certain area, you'd have more options in certain models of care than if you lived in regional and remote areas. Obviously, it's going to be a different situation out there. Yeah. Why do you think it is? Why do you think the Australian sort of system is the way it is in terms of just the way that we've developed into a country or a healthcare system where the default is for women to give birth in hospitals, or where there's this kind of really, if you look at the stats, there's really high numbers of women being induced or having planned cesareans and stuff like that? Why do you think the process?
That's such a big question to answer, because there are multiple reasons why this is the case. So historically, way back in the early 19th century, 20s and 30s or whatever, women were cared for at home, everyone had their babies at home, and then midwifery became regulated, GPs became involved in maternity care, it became a lucrative source of income for them. The community midwives were pretty much pushed out. Hospital became the place. It became a fashionable place to have a baby. The sort of people looked up to the people with money and power. Those women were having their babies in hospital, so the other sectors of society thought that was a good place to have their babies. So it was a very socio-cultural shift, but it was exacerbated by regulation system, which was, I mean, it's important to regulate health professionals, so I'm not saying that was a bad thing at all, but midwifery was very community based, and it definitely changed from home to hospital reasonably rapidly. Anyway, but that's a whole history book to be written that I can't really talk about right now in this short interview. But and the other question you had was why is it more prevalent for women to have more intervention in birth?
Yes.
Again, a really big topic, but that has been something to sort of fight against, really, because there's a lot of intervention that occurs which is unnecessary. There's a lot of research out there that shows your carer who looks after you in pregnancy, labour, birth can have a massive influence on how much intervention you have. It is really, again, very many reasons why the intervention rate has increased so much over the years. I mean, it's related to the fact women have babies in hospital, number one. Hospital is, it's not necessarily the best place to have your baby. Being pregnant and having a baby doesn't have to be a medical event. Home birth in this country is pretty low statistically, not many, maybe a couple in 100. Depends where you are, even less than 1 in 100 women will have their babies at home. It is the most appropriate place to have your baby in some respects for women with low risk of obstetric complications, especially when there are systems in place when that midwife can have backup care. So that's why my interest and my PhD interest was publicly funded models of care of home birth. So there's only 15 of them in the country. So each hospital and each area and district should have one of these models, but they don't. So there is a pushback against home birth because some women have had negative outcomes of home birth, and then it can be argued that those women might have had problems in their pregnancy, and they're probably not the best candidates to have a baby at home. So there are always women out there that will need medical help, and that's when maternity units in hospitals are the best place for them to have their babies. But the negative aspects of home birth are the ones that get splashed into the media, and that's when it can be very polarizing. So intervention in birth can be very necessary, but it can also be incredibly unnecessary. But women get led by their carer, and if you look at all the research in relation to midwifery-led care, you are more likely to have less intervention, and women prefer that relational type of care. And that continuity, knowing that trusted midwife all the way through. But in relation to sort of intervention, I think women have to choose carefully who they decide to look after them at the beginning of their pregnancy. But like we had the conversation earlier about, they often don't know what their options are. So that's a bit of a hurdle to jump through.
Yeah, of course. Okay, well, thank you so much. I found this so interesting. And
I'm not sure if I've answered those questions brilliantly well, but anyway.
Thank you so much. That was really great. Well, Dr. Catling, she is just too humble. That really was an amazing insight, and it really got me thinking more about all the different ways there are to have a baby. I suppose when it comes to your health, education and empowerment is key. Thanks so much for joining us on this episode of Alive and Kicking. We can't wait to be back here soon, busting some more myths.